about endoscopic cartilage button tympanoplasty. Even though we're going to talk about this in an endoscopic way, this is something you can do with a microscope, you can do it in the clinic, you can do it in the operating room. And I would argue that this is a really good procedure to start off with because it will be faster than what you would have done with the microscope. And I'll show you why that is. So the history of this technique, it's based on microscopic techniques. I learned it from a guy named Richard Gonzalez, who you've never heard of, who works at a Kaiser Hospital in the San Francisco Bay Area near San Jose, but he doesn't really publish any things that he works on. He originally described it with lidocaine injection of the ear canal, which you do not need to do. In fact, I wouldn't recommend you do it because your patients will get dizzy. And the amount of rimming of the perforation that you need to do is actually very little, I think, and I've done less and less as time has gone on. Roland Evie, who is now the chair of otolaryngology at Vanderbilt, which is in Tennessee in the U.S., used to be at the Mass Eye and Ear, described cartilage butterfly in kids in 1998. If you look in the literature in PubMed, there's lots of articles now on various aspects of cartilage button tympanoplasty. It's somewhat analogous to cartilage palisade tympanoplasty, which was mentioned earlier today. So this is the entire talk in one slide. Basically, the procedure that we're doing here is we're usually taking an anterior perforation because that would be hard to get at for an underlay transcanal tympanoplasty, and cutting out a piece of cartilage from, just like Dan did in the video. We're cutting out usually a circle because most of these perforations are circular. They're usually from a tympanostomy tube. So you're cutting out something that looks like a tympanostomy tube and cutting a groove in the middle of it and then putting it in just like a tympanostomy tube. So that's basically the entire procedure in one slide. Let's go over it in a little bit more detail. So I would say the indications for this procedure is you want the edge of the perforation more than 1 or 2 millimeters from the annulus or malleus. Otherwise, the cartilage butterfly graft won't mate appropriately with the eardrum. You want a round or oval shape. I think if it's a kidney bean shape, it's going to be hard to carve your cartilage to fit that. You definitely want a dry ear. So if you try to do this in an ear that's infected or draining, I promise you it will not work. I have tried and I have failed a few times. So I think traditional underlay tympanoplasty in the operating room, like what Dan did today, if that ear was draining, I think you could expect a pretty similar result to a dry ear. But if you're going to do a cartilage button technique, definitely do it in a dry ear because it will not work in an infected ear. And I think really the best indication here is an anterior perforation that would otherwise require a post-auricular microscopic approach to get so far anteriorly, so if there's a large bony anterior canal wall overhang, for example. You can do this in a semi-sterile fashion in the clinic, either with a microscope or endoscope. You can use the suctions to size the perforation. So in America, I think maybe it's the same here, the suctions are labeled by the French. So 3 French is 1 millimeter. So a 7 French suction would be a little 2 1/3 millimeters. I usually start by just putting antibiotic drops of some sort in the ear canal, and then I just betadine prep the conchal bowl if we're doing this in the clinic. I do a full prep if we're doing it in the OR, but you could definitely do this under local in the OR if you wanted to. The post-auricular harvest is very similar to what Dan showed, except I just do it with an 11 blade, so you don't have to use 2 blades. It kind of speeds things up. You can also use something called a dermatologic punch, which is basically creates a perfect circle. It's used by the dermatologist to remove moles or possible skin cancers, and they come in various sizes, up to 6 or 7 millimeters. So you can use this to get a perfect circle every time instead of having to try to carve it by hand, as Dan did. The cartilage button should, of course, be bigger than the perforation, usually about 2 millimeters. You always want to start big because you can make it smaller, but you can't make it bigger. But even if you end up too small, you can just take another one. There's plenty of cartilage, so you can certainly take more than 1 graft, but it just slows you down. I would irrigate the wound if we're doing it in the clinic with the same drops I put in the ear canal, and then just close with sutures or steri strips. So here's a picture. This is a clinic case where we're taking a graft, just like Dan did in the case we just saw in the antitragus. And then here we are using the dermatologic punch. I don't know what size that is, maybe a 4, and so that'll give you a perfect circle just about every time. And then you prepare the cartilage button on the back table using the 11 blade. You cut along the circumference of the cartilage and then trim the graft as needed. And as Dan said, you'd like to place the incision low on the concha bowl for the best cosmetic result. If you put it up here, they'll have a perfect circle of hematoma that they'll see in the mirror. And so if you put it down here, you can hide it quite well. You could take this from the tragus too if you wanted. It's maybe a little bit easier technically to do it from the concha, but you could do the tragus. This is a very bad drawing by me of what you were trying to do here. We're taking an 11 blade and basically you're going around the circle almost like putting a tread in a tire. And then the natural elasticity of the cartilage will tend to make the cartilage open up so it ends up looking like a grommet tympanostomy tube when you're done, except that there's no lumen in the middle. And you can do this with perichondrium, without perichondrium, it probably doesn't really matter. So here's a real one, what it looks like. You can see we've left a little bit of perichondrium on this one here. That's sort of another picture of one. So then the cartilage insertion, you can partially rim or rough up the perforation to aid in vascularization. Turns out when you're putting this in, it roughs up the eardrum enough, meaning it kind of self-rims. So I've done less and less rimming over the years, which makes, of course, the perforation smaller that you're fixing. And then you grasp the outer flange with the alligator forceps, you insert the anterior portion of the graft, and then use a needle or right angle hook to get all of the medial flange underneath the tympanic membrane, again, just like a grommet tube. And then I put antibiotic ear drops in the ear, and that's it. And we've got some pictures here, and I'll show you a video. So this is a perfectly round perforation that's anterior from a prior tympanostomy tube, and so this would be very hard to get at for an underlay approach. You could try to go anteriorly with the endoscope and just elevate a flap anteriorly on the ear canal and then do an underlay graft here, but that is going to take much longer than this technique. And so again, I think this is a great way to start with endoscopic ear surgery, because when you start with endoscopic ear surgery, it's going to slow you down. But in this particular situation, endoscopic ear surgery will actually speed up the case. So that's what it looks like when it's in. You can see that you can only see the outer flange, and these things seal in pretty nicely. So let's show you a video example. Instead of showing you a really simple case that works beautifully, I'm going to show you a really difficult case where I made some mistakes, so that hopefully you don't have to repeat them, and I've already done it for you. So this was a 25-year-old who had a prior right tympanomastoidectomy elsewhere, and then he developed a perforation after diving into a lake and fell on his ear. He had an anterior perforation that I couldn't even see in the clinic with a microscope. He just developed a hearing loss. He had a large volume flat tympanogram, and he had such a tortuous ear canal that you could not see the perforation, nor really the majority of the eardrum in the clinic through the microscope. So he absolutely refused the post-auricular incision because he had a bad time the first time around, and he was maybe just not quite right. But he refused. He wanted it closed because it bothered him, but he refused the post-auricular incision. So he's a perfect guy to try endoscopic cartilage button on, and that's what we did. So let's see if we get our video to play. So we're going to start by trimming the hairs. I do usually trim the ear hairs at the start of the case. I think that helps to avoid smudging of the endoscope. And so there's a lot of tympanosclerosis here. There's a perforation anteriorly, so I broke one of my own rules here. It's marginal. It's right near the margin. This is the malleus. This is some tympanosclerosis. So we're trying to rim the perforation there and just get a good look at it. I didn't show you the taking of the graft, but here we've carved it halfway. I don't usually do it under an endoscope. I just do it freehand, or usually the residents do it because their eyes are younger and they can see this much easier than I can. So that's basically what it looks like when you're done. this one we don't really have perichondrium on. And so my perforation, which is oval, but unfortunately my graft is circular, so I'm going to struggle to get it in, both because it's near the anterior bone, the annulus, so there's really not enough room for the cartilage graft, so you're going to watch me struggle here for a while to try to get it in. And this was also a difficult access situation where we could see with a 30-degree or 45-degree endoscope. I can't quite recall, but it's hard to get the instruments in. I usually don't do any local injection at all. I think that just makes it bleed more, so the bleeding you see. So now the mistake I made is I pushed it all the way through. So now I'm struggling, and I'm struggling also to reach there because I can't get a Belucci's in there. I can't really get a cup forceps. So what ended up happening is we just pushed it down even farther, and I took another graft, but I learned a little something, and I left some perichondrium on it so I could fish it back out if I did the same thing again. And so you're going to watch us put it in again. And again, it's a bit of a struggle to work around the corner, because even though, just like the first stapes case we saw, even though we can see pretty well, and this is a case from a few years ago, we don't really have the angles of the instruments that we would like to try to get the graft in there. And again, we're trying to get the inner flange underneath the eardrum and keep the outer flange on the outside. And eventually I did get it in. Unfortunately, I don't have the video of that, but there was at the superior aspect of the perforation, there was still a bit of an opening because my cartilage graft wasn't big enough and was circular while the perforation was oval, and so I took a little extra perichondrium and put it through the hole just like a fat graft. Which brings up sort of the obvious question, well, why not just do a fat graft in this situation? And that's certainly an option. You have to be a pretty big fat graft, but that would be another option. So the results in this case, the cartilage graft healed, but there was a residual 1 millimeter perforation superiorly where I put the perichondrium. In the meantime, he actually healed up on his own. And so about a year after this procedure, he healed on his own. I could see that in the clinic. I'm sorry, I don't have the picture, but he was happy. His hearing improved. He didn't have the ear fullness. And so the learning points here were that an oval-shaped perforation is hard to close, particularly with a circular graft. So if you're going to do that, maybe use a big derm punch and then carve it to an oval shape. And then you can also place gel film or gel foam through the perforation to keep from dunking the graft or pushing it through. But even if you push it through, you can always get another graft. The questions that, in terms of post-operative care, I usually have the patients finish a bottle of antibiotic eardrops, and then I'll have them follow up in 1 week just to make sure the donor site is healing well. When you see these patients, you're going to look in there and the cartilage graft is going to look white. You're not going to be sure is it in it or is it not. Leave it alone. If you don't want to go in there and play and suction, just leave it alone. It's either going to work or it won't. To resist the urge to suction or manipulate the graft, I usually see them for their second follow-up in about 3 months. And at that point, I'd say only about 50% of them have epithelialized. So the cartilage graft can stay white like cartilage without a lateral surface of epithelium for a year or two. In some cases, it's okay. Just leave it alone. It will eventually heal. And then a 1 or 2 year follow-up to check for cholesteatoma. I've been surprised that I've never seen a cholesteatoma in one of these cases. And I'm not the only surgeon that does them in our institution. We have a lot of the pediatric surgeons really like this for post-tympanoplasty tube anterior perforations. And I've never seen a cholesteatoma, which I'm a little bit surprised by. You would think that we would have seen one by now, but I've never seen it kind of cholesteatoma. The benefits of this procedure, I'd say it's an excellent introduction to endoscopic ear surgery, because your lateral to the eardrum bleeding isn't an issue because you don't need to do any injection at all. So as long as you don't scrape up the ear canal, it's going to be a pretty straightforward case. There's no post-auricular incision. You can do this in 15 to 30 minutes or so. It's safe. The acoustic results approximate underlay techniques. I tell patients when we're considering this that the results, the chance of success is probably a little bit lower than traditional underlay techniques. So I quote them somewhere in the 2/3 to 75% range, maybe a little bit better. So that might be the one drawback. When we looked at our data, we had about a 2/3 to 75% success rate with this procedure. Of course, if it doesn't work, you can go back and do an underlay technique. It's probably not a great technique for a perforation that abuts the malleus and or annulus. You might want to use a large fat graft for that, or possibly just the traditional underlay techniques. Bleeding can be an issue just with like any endoscopic ear surgery, but again, I would say this bleeds less than most underlay procedures because you're not lifting a flap. It's an evolving procedure. The amount of rimming I do has definitely gone down to almost no rimming over the years. You want to choose the right patient for this. So patients with a big anterior bony canal wall overhang are good. And like I said, I think you can do this in the clinic. I've done them microscopically in the clinic many times, so particularly on older patients. So the classic patient would be someone who wants to wear a hearing aid but also has a perforation, but when they wear their hearing aid, the ear drains, so they can't really wear their hearing aid because they have a mixed loss. And so those are patients that you can close in the clinic so they don't have the risk of general anesthesia. So this is another surgeon named Phil Littlefield, who is in endoscopic ear surgery, was in the military, is now in private practice in San Diego, showed me this post-op picture, and this is the perfect kind of patient, a cranky old guy who was not a general anesthesia candidate, so meaning an old patient who they couldn't take to the operating room, but this is what one of these grafts can look like when it's built up. So that is a quick overview of endoscopic cartilage button tympanoplasty. We'll get to do that in